So coming back to my topic is making critical decisions in the treatment of EGFR mutated NSCLC. And the question I had raised is because it makes a huge impact whether we are supposed to use osimertinib first line or should we wait for the progression. And the hurdles keep on coming as we grow older and older. So one of the important question that comes to my mind is, what if the patient fails on osimertinib? So that's why I raised this question. Next slide, please. As per the Globocon 2018, lung cancer, when both the sexes are combined, lung cancer is the most commonly diagnosed cancer, leading to, it's a leading cause of cancer death. Next. Next, please. So the parameters which determine the choice of first-line treatment in advanced EGFR mutated, especially DEL19 and L858R NSCLCs, the parameters includes PFS, OS, overall response rate, presence of brain mets, safety and toxicity, quality of life, patients receiving subsequent therapy on progression. The most important point which comes to my mind is this: what if I burnt osimertinib upfront? And let us keep cost aside. Next slide, please. So osimertinib provided unprecedented improvement in PFS among all the three generations of TKI, whether it's first generation, second generation, or third generation. Osimertinib has shown a PFS of nearly 18.9 months, which is relatively very high when compared to geftinib or other arm. It's relatively high. Next slide, please. As you can see in all the three studies, whether it's Lux Lung 7, whether it's Archer, or whether it's Flora, in Lux Lung 7, the separation of the graph starts after 12 months, whereas in Archer, it's somewhere around 6 months, whereas in Flora, there was immediate separation of the graph, demonstrating the heavy activity of the molecule. In this, the point which has to be noticed is only 2 trials have included the patients with brain mets, that is Lux Lung 7 and Flora. Next slide, please. Next. So when we see the overall response rate and the median duration of response, here also Flora predominates, showing the highest response rate of nearly 80%, though the comparator are in the range of 70 or 75, but it's the highest of 80%. Whereas the duration of response was nearly 17.2 months with osimertinib, whereas it was for afatinib, it was nearly 10.1 months, and for dacometinib, it was 14.8 months. So again, the osimertinib has taken the lead here. Next slide, please. Next. So as you can see very well, this is the first time an EGFR TKI has translated PFS to a significant OS benefit. You can see the graph is separating at all the 3 points, that is at 1 year, 2 years, and 3 years, with a gap of nearly 10% or more in between, showing a median OS of more than 3 years with osimertinib. Osimertinib patients were more likely to be alive at 2nd and 3rd year. With 3rd year, nearly 54% of patients are alive. Next slide, please. So the Lux Lung 7 and Archer 1050, they failed to demonstrate any OS benefit in either of the studies. Next slide, please. And this has been concluded by Canadian consensus as well. Next slide, please. So coming back to that, 28% of the patients were still receiving osimertinib at 3 years, which was nearly 3 times more than the patients in the comparative arm. When the study was concluded, even at that time, 22% of the patients were still at the treatment arm. Next slide, please. So the beauty of osimertinib is it has shown superior efficacy in the patients who are having either de novo CNS mets or the chances of brain mets developing in the patients receiving osimertinib is also quite low. When you compare the CNS progression, it occurred in nearly 6% of the patients receiving osimertinib, whereas nearly in 15% of the patients receiving standard of care. When you compare in uh, divided from the patients who had initial CNS mets, the median PFS was 15.2 months versus 9.6 months with a positive hazard. Same applies to the patient who had not any brain mets at the time of enrollment to the study, of showing a PFS of nearly 19.1 months versus 10.9 months. Next slide, please. Next slide. So, a significant CNS response to first-line osimertinib in patients with EGFR mutated advanced NSCLC and the patients with CNS mets. Intracranial or CNS response was not assessed in Lux Lung 7, 3 or 6. Though systemic clinical benefit was observed in patients with afatinib on afatinib arm versus chemotherapy, but not with gefitinib. Patients with brain mets were excluded in Archer 1050 decometinib trial. Next slide, please. So when you assess for the safety, it's not about only the response, it's also about the safety profile. As we all are aware, the safety profile of osimertinib is much more safe compared to both the second generation TKI. Osimertinib arm showing grade 3 AEs of nearly 18% in Flora, whereas in Lux Lung 7, it was 31%. In Archer, it was 63%, which was quite high. So next slide, please. As you can see, osimertinib is a safe to handle drug with a skin toxicity in less than 1%, paronychia less than 1%, diarrhea in hardly 2% of the patients, and stomatitis, which we had seen in many of the patients who have received either gefitinib and or erlotinib. It was hardly 1% when used osimertinib upfront. Next slide, please. So even the dose reduction due to toxicity is very less in Flora trial compared to Archer and Lux Lung 7. Next slide, please. So the global quality of data was, the global quality of life was maintained in the decometinib group in Archer 1050 but was significantly improved in the gefitinib arm, showing gefitinib superiority in quality of life in Archer 1050, whereas in Flora trial, the global quality of life was improved from baseline in both osimertinib and EGFR TKR comparative group with no clinically relevant differences between the groups. Next slide, please. So most of the time in the initial phases, what we thought is to wait till the time T790 mutation on the second line, we may use osimertinib, but does this hold true? Because most of the patients, when they progress on first line, they will not be there. Nearly 30% of the patient will miss the second line treatment. So do I really keep osimertinib as a reserve drug? I doubt it. 1/3 of the patients of all EGFR mutate patients treated with first and second generation EGFR TKI are able to receive second line osimertinib only. So what happens to the remaining? Some of the patients die off, and some of the patients it's not feasible to biopsy, either a liquid biopsy or a solid biopsy. And some of the patients, they may not have EGF 7T90, T790M mutation. So again, question whether really to wait for T790M mutation to wait and then start osimertinib, or to think of osimertinib upfront, because not possible to predict who will develop T790M mutation, because once there is a progression, it may be because of EGFR, it may be because of HER2, MET, or any other driver mutation which is there whenever there is a progression. So ideal way is whenever there is a progression, you should document what is the reason of progression, whether it's the same or it's the different. I was just going through the literature. They say that whenever there is a progression on osimertinib, you may or may not continue osimertinib and add on either second generation TKI or first generation TKI, do the NGS, analyze what is the reason of progression, and then think of what is the next line of treatment. Because as Dr. Amol has elaborated in the talk previously, it's not necessary that immunotherapy may work or may not work. Chemotherapy may work or may not work. But ideal is you should do NGS, analyze the things, and then decide. So approximately 1/3 of the patients will not have access to second line treatment. So it's better to use osimertinib upfront. In the real world evidence from Japanese and Taiwanese study is whenever they used afatinib upfront, there are less than 50%. Next slide, please. Next. So less than 50% patients put on afatinib acquire T790M mutation. So again, you are not sure whether at that particular time the drug will work or not work. So better to use the best drug upfront. Next slide, please. The reasons why I am forcing it again that using first generation or second generation TKI is not an optimal clinical care, because we are not smart enough to figure out who will develop EGFR T790M mutation. And even if he develop, whether osimertinib will work at that time, we are not sure. Not everyone will be well enough to receive additional treatment. Nearly 30% of the patient don't receive any subsequent treatment. So you are going to lose again 30%. Tissues liquid biopsies are always not always successful. And osimertinib undoubtedly is associated with significant survival benefit as first-line therapy. Next slide, please. Uncontrollable factors in sequencing is toxicity to drugs, occurrence of mutation, sites of progression. So suppose there is a slow progressive disease, you may still continue for osimertinib, wait for some more time, or if there is a oligoprogressive disease, there is a beautiful term named as oligoprogressive disease. At that time, you can use some other modality and continue with osimertinib. With concurrent morbidities like age, or the patient is not in a good shape, then you are supposed to think of other factors, and patient's choice, the most important thing. Next slide, please. Even as per NCCN, the first preferred regime is osimertinib. No doubt, we can always use first or second generation TKI with or without chemotherapy in the EGFR mutated patients. Next slide, please. So, in summary, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in OS. The median OS benefit of greater than 3 years sets a new benchmark for osimertinib and provides a window of opportunity for the management of patients with stage 4 NSCLC with sensitizing mutation, reaffirming its importance as the first-line therapy. FLORA is the first time an EGFR TKI has translated PFS into an OS benefit. Nearly 30% of the patient remained on osimertinib at 3 years. So the magic number is here is 3, because 30% patients at 3 years, if you're not going to use upfront, you're going to lose nearly 30% of the patient. Osimertinib is the only drug which can be given in patients with brain mets, as we all are aware, and with T790M mutation. In some of the patients, even you can try with, when there is a progression on osimertinib 80 milligram, you can try with osimertinib 160 milligram. Some of the places they even recommend it. Osimertinib is the safest and least toxic drug among all the available options. Sequencing can't be considered the best strategy, as almost 70% of the patients are not eligible to receive osimertinib in the second line, because we are not aware whether that progression has occurred because of the EGFR mutation driver mutation change or because of some other reason. So these data confirm osimertinib as the first-line standard of care in metastatic EGFR mutated, especially DEL19 and L858R NSCLC. Next slide, please. Thank you.